All right, let's get started. It is 35. So thank you everyone for coming, and I guess good evening to everyone as well. I am Jonathan. I'm the one of the co-presidents for MedLife. And I welcome to our virtual Med Talks for 2023. And yeah, thank you all for coming. We're very excited to have these amazing speakers with us today, and we really look forward to the engaging discussions and questions that uh, everyone may have. And before we get into kind of like the logistics of the event, Michael, the other co-president of MedLife, will be sharing the motivation behind this event.
All right. Hi, everybody. So my name is Michael. I'm the other co-president of MedLife. So MedTalks is an annual event that we hold that features talks by distinguished professionals who work to promote public health, medicine, education, and/or development. So as a club on campus, we wanted to use this platform to allow for meaningful conversations within public health and with public health professionals to learn more about some of the most pressing issues in public health today, as well as generate some ideas of how we may be able to become involved in such issues as students. And so in the past, this event has been used as an opportunity to engage with experts in the field about their work. And so we didn't want to take that away, take away the interactivity of it even in this online setting. So we want you guys to definitely ask questions, be engaged, and have some really great conversations about these specific fields.
Okay, well, good evening, everyone. It is my privilege tonight to introduce Dr. Banks. Dr. Banks is an assistant professor of anesthesiology and critical care medicine at Johns Hopkins University School of Medicine, where he also serves as the co-course director of optimal anesthesia management. After earning his MD from the University of Pittsburgh, Dr. Banks performed a fellowship in microbiology and immunology, and then 2 more fellowships in surgery and critical care medicine. Welcome, Dr. Banks. We are so honored to have you tonight and can't wait to hear more about you.
Hello, everyone. Hi, how are you? It's a pleasure to meet everybody. Let me, it's going to change my view. Excellent. Okay, I can see everyone now. Well, thank you very much for inviting me. And thank you for the introduction. Yes, I am assistant professor in the Department of Anesthesiology and Critical Care Medicine. I serve as, currently I'm one of the assistant program directors for the anesthesiology residency program. And I'm also the vice chair for diversity, equity, and inclusion for the Department of Anesthesiology and Critical Care Medicine. And in July, I'll actually be the program director for the Critical Care Fellowship. I am a graduate of the Johns Hopkins University. I graduated in 1992. And then I did also get my master's in education and health professions from the School of Education in 2018. And currently I develop a lot of programs to help promote people who are underrepresented in medicine and healthcare to go into academic medicine. So I have we do several programs to help increase that, increase medical student, help medical students. And I also do some mentoring for a few undergraduate students as well. Anything, do you want me to tell you some more things about anesthesiology and healthcare in general? Mike or Isabel? Okay, so I'll talk you through my road to medicine, to health, and to anesthesiology. So I always wanted to go into medicine, but didn't really know what field, because medicine is a broad field. When I came to Hopkins, I was very excited. I started off as a biology major and pre-med. At that time, there wasn't, in the 1988 and 1990s, we didn't have as many majors as you guys have now. So it was biology, chemistry, all the physical sciences. Health sciences wasn't an option, nor was any of the health policy majors that exist today from the School of Public Health. We kind of like siloed. When you were in the Homewood campus, you had the schools in the Homewood campus, arts and sciences and engineering. So I started off biology, and biology I enjoyed it, but it wasn't as exciting as I had wanted. And I switched to chemistry, which was really exciting. And PChem is ridiculous. It's got to be one of the hardest courses at that time in the university, next to Phys Found. I think that was the hardest course at that time. And PChem was the second. It was very challenging, but what helped me and motivated me to keep going was that I was with a group of friends, a very diverse group of friends, and we studied together and we motivated each other. And I think that's important in healthcare. That's what's really stressed, is that you can't be one person knowing all. You have to work as a group, as a team, to help with in healthcare, to help patients. And there are so many aspects to healthcare and so many determinants of healthcare that one person cannot do it by themselves. And this is something I learned in undergraduate at Hopkins. So I met a great group of people, and we worked together, we studied together, and we pushed each other and motivated each other and protected each other. I'm sure all of you being undergrads know how cutthroat undergraduate can be in the health professions, and it hasn't changed. Go there. I still go to the Homewood campus. But it's very important to have a group of people who are like-minded as yourself, and who you can work with and trust. As you can see, my background is the Hut, and we studied there many hours together. I and a group of friends. After I graduated from Hopkins, before I did, I applied to medical school, and I think a lot of us, what we did was we all knew that we talked with upperclassmen, and they were all saying, like, you should take one of these prep courses, MCAT prep courses, and it was a very worthwhile investment. And I say that because at Hopkins, they don't teach you how to take standardized tests, because it's not what education is about. It's not about standardized tests. It's about knowing the information and comprehending it and being able to apply it. But people need a very inexpensive way to assess the knowledge that you've acquired. And that can be applied uniformly across all what they believe is across all levels, across everybody. And so that's why they have the standardized tests, the MCATs. I took them to learn how to take standardized tests. I have to say that it does not measure your knowledge capabilities, your intelligence. So don't feel bad if you do poorly, and don't feel great if you do well, because studies have shown that it is not a measure of your intelligence. It just is trying to collect information that medical schools use, but they do not rely on this. I was also on the admissions committee for the School of Medicine at University of Pennsylvania, as well as at Hopkins. And one of the things at Hopkins is that when people look at the MCATs, everyone's like, oh yeah, you did great on the MCATs, but they look at other things. They look at your how you did in your courses, because that's a real measure. If your MCATs aren't great, but you did very well in your courses, you're like, okay, you do know what you're talking about. you do know how to do things. They also look at your other activities, your extracurricular activities. And so in undergraduate, I did do things outside of just studying. I was involved in several different organizations. They had the Black Student Union, and we also had a fraternity, my fraternity, Kappa Alpha Psi, and we did a lot of different activities in the community for people in the city of Baltimore, basically. And what was unique about me was that, and the organizations I was a part of, is that we were consistent. I did this through all 4 years. So it wasn't like I jumped from activity to activity. I think that's very important. You want to, when you do these extracurricular activities, you just don't want to jump around from activity to activity. You want to be consistent. So if you volunteer, you definitely want to stay volunteering and with this, something that is meaningful to you, and you make that activity something unique and reflection of who you are as an individual. Some people, they don't do a lot of volunteer activities. Sometimes they're into sports or clubs, and that's good too. There were some people who were fencing at the time when I was an undergrad, was a club. I think now it's actually a varsity sport, and they're very good at it. Blue Jays are good. So that was, something that's very important that you can be active in. Soccer, women's soccer was also a club, believe it or not. Now it's a varsity sport. I think it's even Division I. It was Division III. Everything was Division III for a while, except for lacrosse. So being involved in either clubs or sporting activities is also important in medical school and in healthcare. After I graduated from Hopkins, I went to University of Pittsburgh School of Medicine from med school. Some of my friends went on to do masters in public health, and that is another option as well. Sometimes when in undergraduate, you are very fortunate. Some of you are very fortunate. You're very blessed with a goal and objectives to achieve that goal. And you're able to do that and proceed on to medical school. But not all of you have that. Sometimes it takes a while for you to find, like, oh my gosh, I really enjoy medicine. And you were an English major or an economics major, political science major, or international relations. That was another big major when I was at Hopkins. And that's fine. That's actually good. You could be a music major and be at Peabody, and that's wonderful. As long as you take those science courses for medical school. And some people went on, they took those courses, but they were kind of late in the application, and they wanted to, sometimes in the process of finding themselves, because that's important in college, you need to find yourself and develop your identity, who you are as an individual. It takes time, and sometimes the first 2 years aren't great. The second 2 years are much better, but you can go on and get a master's of public health and really excel. And I had several friends who got masters of public health. They completed it in I think it's 2 years, and they went on to go on to medical school at great institutions. Some went to Cornell and Chicago, University of Chicago, et cetera. So those are other options to do. If you find that it took you a while to find out who you are as an individual and find out that medicine is that field of human endeavor that you feel that's important for you, and that's going to help you, give you meaning and purpose and fulfillment. In medical school, I'm going to tell you this right now, is that each time you go from one school level to the next, it's going to get harder. So going from high school to college was challenging. Going from college to medical school is going to be more challenging. It's going to be, and it's not hard, because I see it as a challenge, because it's something that you want to do, and you're going to be faced with many challenges that are going to test you. medical school, many of you have taken, some of you may have taken molecular cell biology for pre-med courses. Okay, that is a medical school level course. We did that entire year in 3 months. So I was, yeah, wow, exactly. It was, that's how medical school goes. Genetics was a semester. Genetics is done in a month. Okay. You're very fortunate here that you're taking courses that are actually taught in medical school. The textbook that you're using is used in medical school, and in the finest medical schools. So when I had my molecular cell biology, it was the same textbook I had in undergrad. I was like, oh yeah, I don't have to buy it. I already got it. Same thing with genetics. Cellular biology, same textbook. So that saved me some money. But it showed you that you're very fortunate. This institution, the pre-med curriculum, does prepare you, and use that to your advantage. Apply yourself with the same determination that you applied yourself to get into medical school, and really build that foundation, because it's what you're going to need to reflect on as you're going forward in your clinical years and on after into residency. And that was a lesson that I learned, fortunately, the easy way. And I studied really hard. I was like, oh yeah, I'm very fortunate. I recall these and I remember some of these things that were learned, but I learned them even better. And it helped me to build on my next courses. All knowledge is transferable. So that knowledge kept on transferring to the next course in medical school, and the next course, and so on and so forth. I continued to study with groups. Medical school, being pass fail now, you really do eliminate a lot of that competition and cutthroat attitude that you may have had in undergrad. It definitely fizzles away, because now everybody is trying to work together, and they're trying to teach you to work together to build that knowledge and that social community to build knowledge. So I definitely want you to continue to do that in your first 2 years of medical school. The second 2 years, well, just to go back a little bit further, you do have to take some more standardized exams. You just never get rid of it. I'm sorry. It's the evil that will continue to follow you for the rest of your career in medicine. I don't care if you go into physician or you're a nurse, physical therapist. In healthcare, they want you to take a test, and then you pass the test in order to get board certified, so that the lay people can say, all right, we trust you. And I'm telling you the gospel truth. I don't know how you can build trust in a person that passes a standardized exam, because it's meaningless. It's actually how you apply that knowledge. But so be it. That's what they want. That's what people want. They want you to be board certified. In order to get that certification, you got to pass tests. So after you take your MCATs, you're not done. You're going to take what's called United States Medical Licensing Exam. And the USMLE comes in, it's 3 parts. There's the one you take in the first year, standardized exam, and it goes over all the knowledge that you gained in the first 2 years. That's probably the hardest one. Medical schools are very, they realize that it's the hardest one, and they're going to give you time to study for it. So you get like 6 weeks or more to study for the exam. Some places, Hopkins gives you 4 weeks or 8 weeks, excuse me. So the Hopkins Medical School gives you 8 weeks, which is great. 2 months to study for the exam. And so generally, Hopkins medical students do very well. They pass it because 8 months, 8 weeks is very good, very generous. But nonetheless, you get 8 weeks to study for this exam. Then you go on to your clinical rotations. And those are your clinical rotations, the challenge here, and this is very important when you're in medical school that you know this, the rotations that you do first help determine where you're going to go to residency. So let's say you want to be a cardiologist. You want to start with internal medicine, either your first or in the first 6 months, because you want to get through there. You want to get a good evaluation. You want to get the grades, the evaluations, so that you can get letters of recommendation from faculty. Same thing of surgery or something like that. Now, let's say you want to do the highly competitive fields of medicine, such as neurosurgery or dermatology, things like that. Those you want to have early as well, because they're very competitive and you need to get a letter, and they actually match early. So you really want to get that in the first 6 months of your third year, so that you can get these evaluations and get them out as early as, actually not even the first 6 months, probably in the first, you start in July. So yeah, before you want to be completed, but with the disciplines that you think you're gonna do residency in, have them completed by December. So you have to finish them by December, so that you can get letters of recommendation, so that you can apply by, as soon as possible, like by January or something like that. You need to get these letters out and everything applied, because you're going to start interviewing in your 4th year. For neurosurgery and everything like that, you're interviewing like before the 4th year begins. You're going to start interviewing. It's just ridiculous. For all the other disciplines that are not neurosurgery, or the other one is ophthalmology, is also early. The others, like orthopedic surgery, medicine, anesthesiology, we interview regular. But you still want to get them done early so you can get these letters. There are 6 core rotations that you will take in your 3rd year that are important to work on. That's internal medicine, pediatrics, family medicine, surgery, psychiatry, and obstetrics and gynecology. You'll rotate on those. And what I suggest is that these are the disciplines that you want to really do as well as you can. How do you do as well as you can? You have to show enthusiasm, read, and be willing to stay to learn as much as you can. How do you show enthusiasm for a subject that you don't like, for a field that you don't like? I'm going to tell you, I don't like psychiatry. Just don't. Never did, never will. But I faked it till I made it. That's saying fake it till you make it. You got to fake it till you make it. You have to show enthusiasm. You're there, you read. And what I did was I made objectives. I want to learn about mood disorders. I want to learn about depression, anxiety, bipolar, all those things. The other personality disorders wasn't as interesting to me, but I know these mood disorders are very common. These are the common things that need to be learned, and I want to learn as much. So I made objectives for myself. I read about them, and I asked a lot of questions, and I showed interest in mood disorders, and they ate it up. They loved it, and that's how I did well in psychiatry. Same thing with obstetrics and gynecology. Wasn't a big fan, but I loved endocrinology, and I really showed a lot of interest in understanding the gynecologic endocrinology portion of my rotation, and I did very well. Going on, I'll go quickly now since the time is of the essence, but after when it comes to residency is just like medical school. You have to show, applying for residency is just like applying for medical school. You have to show them that, one, you are interested in their field. So you want to get good evaluations and good grades in that area. So you rotate through those areas, and you want to get good evaluations and grades for that area. And they also look your test scores for the USMLE step 1. It's pass fail. So don't look at much of that. Step 2 is graded, is scored, but it's going to be pass fail coming up in a few years as well. So you just want to make sure you pass those, and that's very important to pass them. But I would say, once again, when it comes to extracurricular activities, you will have time in medical school to do these extracurricular activities, to be involved in clubs and government, etc. And you definitely want to see yourself involved in these, making these activities and projects a reflection of who you are as an individual. In choosing a residency, I think the exciting thing for how do you determine what you want to do is you want to find that field that really stimulates your interest in becoming a physician. What is it that makes you say that medicine is what I want to do? For me, anesthesiology, what I love about it is the ability to do procedures, to work with my hands, as well as to do to work with medications and drugs that I found incredible during my first and second years. And for me, it was just excitement. Plus, I also like doing critical care. So you can also do critical care in anesthesiology. And that's why I say it's very important to do as much as you can in medical school, do as many rotations as possible, because you really get to see these things. Even as undergraduates, I encourage you to come to the hospital, to the downtown campus, and to see the different disciplines in medicine. There are disciplines that you may never have heard of, like radiation oncology. The ones that everybody knows that are really sexy are surgery and emergency medicine, internal medicine, because you see those on TV. But radiation oncology is a great profession. Physical medicine and rehabilitation is another excellent profession in medicine. Ophthalmology. I would say right now, as undergraduates, I would take some time and find some mentors in the hospital, in the School of Medicine, who can walk you through a day in the life of whatever field that interests you. And just stay for a few hours to see what it's like in the clinic or in the operating room, or in wherever unit they are at, to really absorb that. And that gives you an idea and a flavor of what there is out there. There's opportunities to do research, but that will come, and you'll learn about it as you talk with individuals and mentors. But just to get the experience and exposure is important, and they'll help to really give you an idea of what it's like to be a physician. I definitely took that opportunity. I worked in Dr. Peter Ketrovich's lab. He was an internal medicine and cardiologist, and I had a wonderful experience. I got to meet some incredible people. I met a surgeon who introduced me to some incredible procedures. That's how I started to really enjoy surgery and anesthesiology. So I highly recommend that you take that opportunity to do that. Is that pretty good? I took a lot of time. There's a lot to say.
That was wonderful.
Any questions?
Thanks. Thank you so much for coming out to speak to us. It was really, really helpful advice. All right. If there's no questions, we're going to move right along to the next speaker. Thank you again.
So our next speaker will be.
I'm sorry, Jonathan. Go ahead. Sorry about that.
Sorry, I wanted to introduce you. Our next speaker is Dr. Raj Mukherjee, Assistant Professor of Neurosurgery and Director of Neurosurgical Oncology at the Johns Hopkins Bayview Medical Center. Dr. Mukherjee graduated from the Geisel School of Medicine at Dartmouth, completed his neurosurgery residency program at Cedars-Sinai Medical Center, and his fellowship at the University of Pittsburgh Medical Center's Center for Skull-Based Surgery. Dr. Mukherjee's research involves disease-specific quality of life instruments, and he leads national efforts in creating brain tumor patient registries and adaptive clinical trials in neurosurgery. Without further ado, let's give Dr. Mukherjee a warm welcome.
Great. Thanks, Jonathan, and thanks, Stephen, for the introduction and for the opportunity to speak. A couple things. I'm not sure if Dr. Banks is still on, but it was great to hear at least the end of his talk. We share a connection at Pittsburgh. I think he was trained there for a bit or went to medical school there. So to be honest with you, I have like a whole bunch of slides to present. But maybe I didn't quite understand the assignment. So based on the last talk, are these, could I just clarify for Jonathan or Stephen, do you want me to give a formal talk or do you want it to be an informal kind of discussion?
Either or. A lot of our past speakers have presented slides and it's been really helpful. So we'd love to have you show them.
Okay. Maybe I will, I'll jump around. You know, generally speaking, when you give a talk, you're not supposed to jump around slides, but maybe I'll do that just to have some hooks, at least for part of the talk. But then we'll leave some time before 8:30 so that we can maybe just interact. So give me 1 second here. So I'm going to share a screen. And apologies for the get up. It's just I'm on call, so I may actually get called while we're doing this, but hopefully not. So a few things. So my name is Raj Mukherjee, born and raised in Chicago, and then I've been all over the country over the last essentially 20 years, even though it doesn't feel like that, since college. Doing undergrad, medical school, and training, and I've been on faculty for about 4.5 years here. I'm an assistant professor, although I'm up for promotion now, which usually happens about 4 or 5 years after you've been at a place, as long as you're doing the right things. And then usually a couple of years after that, you become a full professor. Hopkins is they tend to be relatively slow in that regard when it comes to promotions, but I've been plugging along. I'm an assistant residency program director, so we have the largest neurosurgery residency program in the country with 28 residents, about 4 a year, and that's times 7 years. And so, and some come and go on research and things like that. But between us, Pittsburgh, Baylor, and I think that might be it. Oh, and a place called Barrow Neurological Institute. We're amongst the largest in the country. About a little bit more than 100 people match into neurosurgery each year. And so after medical school, it's a 7-year residency training program. It's the largest, or is the longest training program in medicine. And so if you're into it, it's a great way to know straight away what you're going to be going into. A lot of times, if someone wants to be a cardiologist, you end up spending let's say you're an interventional cardiologist, you end up spending, frankly, 6-7 years in training, because it's 3 years of internal medicine, 2 years of cardiology, another year or 2 in terms of interventional. So I wouldn't let the years in training hinder you from pursuing it. Like Dr. Banks was referring to, if you're exposed to the field and you like it, and you find good mentors and have good experiences, let that guide you. So with all of that context, I figured, part of this was meant to be on disparities in care, and in a lot of my research in the last handful of years, last decade or so, has been looking at disparities in access to neurosurgical care, and especially brain tumor neurosurgery. And some of this research has been funded by some of these groups, especially Robert Wood Johnson Foundation and the National Cancer Institute. So we won't go through all of these kinds of things, but there's a pretty clear racial and ethnic set of disparities in neurosurgical oncology, which means, essentially for brain tumor patients, primary brain tumors like gliomas, like glioblastoma, which is often what you hear about patients having, That can be a really devastating disease where patients really only live for about 1.5 years on average, and also including spread from elsewhere, including brain metastases. So there are disparities in access to care before they ever get to a hospital or to a surgeon. There are described disparities in the delivery of care, meaning folks of certain demographic and ethnic and racial minorities have worse inpatient hospital outcomes, and then in terms of outpatient long-term survival as well. So before you get to the hospital, in the hospital, and afterwards, at each point along along that pathway, there are disparities that are evident, and more important than that, at each point along the way, there are levers that we can pull to hopefully improve those outcomes for those patients. And that's what a lot of my work has been focused on. So with that, in terms of just a general historical perspective, that might be interesting, I suppose, for the group. The first evidence of metastasis when it comes to antiquity goes back to the time, before Christ, and a lot of that is in the Greek literature. Frankly, that's where a lot of our records come from at the time. And so, more than 2,000 years ago, in Greece and in Egypt, there's been discourse on metastases, even going back to the time of Hippocrates. He had a seminal text called The Nature of Man, and it's one of the main tenets of metastasis. And at the time, the thought was that the term metastasis was more related to what was at the time thought of as infection as opposed to cancer. But as the centuries went on, it became evident that metastasis really was spread of cancer and spread of tumor. Galen additionally did work on metastases, and Galen is a person that's particularly known in the neurosurgical literature because he was one of the first that really described the vasculature in the brain, meaning the blood vessels and arteries, and that was really important. That's especially important for us in neurosurgery because those are our pathways to get into and around certain areas of the brain, critical areas, and it's also very important for the spread of metastasis. This is one of the earliest depictions of a breast cancer. And you can see that the breast is, even in this, older, obviously from antiquity illustration, you can see that there are some of the classic changes that we see even nowadays with breast cancer. There's a discoloring, there is changes in the skin, and you can see that they were even surgically trying to excise cancer at that time. And that's around 300 AD. At the time, obviously medicine wasn't as sophisticated as it was now. And so really people would, surgeons and internal medicine doctors would try to balance your four humors: phlegm, blood, yellow bile, and black bile. And it was really felt that black bile was the most associated with cancer and metastasis. And it actually makes sense. When we look at our patients nowadays, many times tumors, when they metastasize to the brain, they look dark, they look black, they look like, frankly, black bile. And so it makes sense that even back in those days, they described things in their way, even though we are a bit more sophisticated about it now. There's a lot of overlap. The first mention of a metastasis in the most modern literature was in the late 1920s, where the New England Journal of Medicine, which had previously been known as the Boston Medical and Surgical Journal, talked about a metastasis. And they even harkened back to the time of Hippocrates and Galen. And so, it's obviously become a huge part of our healthcare burden nowadays. And even then, even in the 1910s, 1920s, metastasis was known to go to certain parts of the brain, and certain parts of the body, including the liver, lungs, and brain. In the more modern times, when it comes to a surgical series and specifically neurosurgical series, the largest and earliest brain metastasis series was done by Dr. Grant, who used to lead the neurosurgical program at University of Pennsylvania. just up the road. It is one of those storied historical programs in surgery, along with Johns Hopkins, Massachusetts General Hospital, Brigham and Women's, and Mayo, that are some of those early pillars in neurosurgery and in medicine. And what's interesting is that in surgery, there is this, it's not that old of a tradition. Surgery is not that old of a tradition. So, it's less than 100 years or so ago that he was operating on people. And so you can actually track the lineage of different surgical traditions. And so, frankly, we're all sons and daughters, grandsons, granddaughters of William Stewart Halsted, who was the first general surgeon at Johns Hopkins. And really the tradition of American surgery comes from Johns Hopkins. And so even Grant has connections to Johns Hopkins. And it's one of the great things about being here is that there's this long and rich tradition that we're still obviously pushing the field forward. This was an en bloc resection, and Dr. Grant was known for doing en bloc resections of brain lesions. And as we look at the more recent data, there's actually good evidence that taking a tumor out en bloc, not in piecemeal, but really taking it out in one piece if you can, is better for progression-free and overall survival. At Johns Hopkins, Harvey Cushing was known as the father of neurosurgery, not just at Johns Hopkins, but really in the world. He was a direct student of William Stewart Halsted, and under Halsted, he had his different students focus in different areas, and Dr. Cushing focused on the brain, spinal cord, and peripheral nerves. And so him and Miss Eisenhart created the first and largest series at the time for brain metastases. She was not a surgeon, but she was his assistant, his surgical assistant, and she's gotten a lot more credit in the last handful of decades for all the work that she did to actually advance the field forward. These are some of his outcomes, which are actually quite good. For the time being, people living, the better part of a year, whereas historically, people had lived for several weeks or so. And so it really showed folks at Hopkins across the country and across the world that improvement could be done. I'm going to skip through a little bit. Here's it's sort of typical surgery for taking out multiple brain metastases. So an incision at the top of the head and in the back of the head behind the ear. This is a case of a patient that I had seen, a 53-year-old who presented with multiple lesions. And so they basically presented with a seizure. And what you're looking at here is a CT scan of the head. The white on the outside is bone. The gray on the inside is brain, normal brain. And the black here is normal brain fluid. A couple of these areas are little bits of calcium, just like on the skull. So all of this looks normal, but generally speaking, if you draw a line straight down the center, you want things to be symmetric. So you have a area of fluid here and here, calcification here and here, but there's this obvious thing that's in the back of the head and on the right. And this looks like it's the left side of the screen, but the radiologists do it such that this is the left side of the head and this is the back of the head. I'm sorry, this is the right side of the head and this is the back of the head. And so in the right back part of the head, in the parietal area, you have a lesion that's a bit bright, so that looks hemorrhagic with some gray swelling around it. And that area of the brain is very prone to seizures, so that's probably what caused the patient's seizure. And then here you see something, if this was on the right back part of the head, this is on the left side of the head. It's dark and it's kind of pushing this area here, which is the brainstem. And so we always get an MRI to follow up. And so this was that area on the right back part of the head that with swelling around it that probably caused the seizure. And then this lesion is actually behind the ear, deep to the left ear and pushing on the brainstem. And so that's in the back of the head. And this is in the top of the head. It's top of the head is prone to have seizures. Back of the head, the cerebellum isn't prone to have seizures, but it can be life-threatening because it can really compress your brainstem and cause you to stop breathing. So they're both really important and both really critical to try to get out. This is just another view of those lesions on the right back part of the head and the left lower part of the head. I'm going to skip past some of that. There were some metastases elsewhere that were noted. This is a chest x-ray where you can see the heart here, the right lung and the left lung, and you can see all this extra stuff here. is indicative of, probably a primary lung tumor. And this looks like a metastasis to the adrenal gland, which is right by the kidney. This is a CT scan where the liver is right here. So, you want to be aware of a lot of different things as a surgeon and as a doctor, including seizure management, getting a diagnosis, taking pressure off of the brainstem, perioperative management. But through the context of all this is that we need to know that, brain metastases are more and more common nowadays, especially as people are living longer. Breast cancer and lung cancer are the biggest causes of metastatic brain cancer, as well as colon cancer. I can skip through some of this, particularly as people get into their, adult working years. That's when the incidence or new development of brain metastases picks up, and it's really driven a lot by lung cancer. As we look at the data for mortality and outcomes, I'm going to skip to some of this, but basically what this is saying is that as you go to a hospital that has more and more admissions per week and per year for brain metastasis, the mortality rate goes down. And same thing is done at the hospital level. So, the more of something that you do, the better you get at it and the lower mortality you have. And this just shows that, as admissions go up, mortality decreases. So based on that volume outcome relationship, this was a paper that I published in JAMA Surgery, about a decade ago. So we looked at all patients that underwent brain tumor surgery. And what we found was there were significant disparities, especially as people got older, in terms of getting admission to high volume centers. So there was a disparity in even getting in through the door. And that happened especially as patients got into elderly age, and particularly actually for Hispanic patients. They had worse and worse access, and patients who were sicker, as noted by a Charlson comorbidity score. There were also relationships between lower income and lower odds of getting into a high volume or quality hospital, and where you lived in terms of, if you lived in an area with high poverty, you were significantly less likely to get admitted to a high volume center. And so that's at least the upstream version of some of those disparities. And then we also looked at disparities within the hospital setting for patients that had brain metastases. So we looked at all the major brain metastases, including colorectal cancer, lung cancer, breast cancer. We looked at all the typical outcomes, or all the typical covariates, age, race, gender, et cetera. And basically the bottom line of all this is that female patients were significantly less likely than male patients to be admitted to, or to have good outcomes, essentially, to have a short length of stay, a short mortality, a good discharge from the hospital. And African-American patients or Black patients across the board had worse outcomes. So even if you get to a high volume center, there's good data that for whatever reason, even after you adjust for comorbidities and how sick the patient is, et cetera, that they stay in the hospital longer and they actually have higher mortality. This is another way of showing some of that same data specifically for lung cancer patients. I'm going to skip through this here. This just goes into some of the data for multiple brain metastases. So for that example of that patient that came in with multiple brain metastases, how do you manage that? Do you just go after the one that's going to cause a seizure? Do you go after the other one that might cause brainstem compression and cause someone to not wake up, or do you go after both? And this was basically the best data that we have, which is not a prospective randomized trial, but a retrospective group, basically a few hundred patients, demonstrating that if you can do it in one setting, go after both. And you want to always go after the more difficult one first. So you want to go after the brainstem one first, and then plop out the easy one up top. And this shows that by doing so, in the long run, patients have better survival. There are differences in terms of how you take out these tumors, and the technical differences with which you take out those tumors. Something that we do in the inpatient setting can have long-term effects on patient survival. So those inpatient complications and those inpatient worse outcomes, regardless of how people get into the hospital, can also impact and have been demonstrated to impact their survival in the long run. This was basically a paper by someone named Dr. Sawaya, who's Lebanese and who's has left MD Anderson's chairmanship after 20 years to actually lead the American University of Beirut to become dean of that university. Recently, he's been a great proponent of diversity in medicine and specifically in neurosurgery. And this was his really seminal paper demonstrating that if you're able to take out a tumor en bloc in one piece, as Dr. Grant did, as opposed to in a piecemeal fashion, you can significantly improve people's outcomes, regardless of their race, regardless of their comorbidity, regardless of their gender. So I'm going to skip past some of this because it's saying a lot of the same thing. And just to go back to our case, the patient did well. They went home within a couple of days. They had less headaches, didn't have any further seizures, and they appropriately had stereotactic radiosurgery or focused radiation afterwards, which has also been demonstrated in the long run to improve survival. So that's one of those levers that we can pull. We talked about some levers that we can pull in the hospital in terms of our surgical technique to improve survival. Post-operatively on an outpatient setting, if we make sure that they get the right type of radiation, we can also improve their survival. Probably the toughest thing to do is to try to help people get in the door to a high volume center. There's some data that I didn't show here from our group that shows that healthcare policies like what is broadly known as the Affordable Care Act actually significantly improved minorities' access to high volume centers and secondarily to better outcomes and survival. This is just a paper by Rao et al. That demonstrated the efficacy of stereotactic radiosurgery in improving patient survival post-op, and that it's these randomized trials that provide us the best level 1 evidence to do the best things we can for our patients. So here are the post-operative images. So there's a resection cavity here from this back tumor. There's a resection cavity here from the top tumor. So everything looks good and clean. And the patient did great. These surgeries tend to take about 4 hours or so, 4 to 6 hours. The blue line the gray line is what was expected. And the blue line is actually what I did. So doing those 2 surgeries in one sitting took about 4 hours. So again, patient did well. And so that's what we talked about, a little bit of historical perspective on neurosurgery in general with some discussion of disparities through an illustrative case, and talking about how we can maybe try to improve some of these disparities before people get to the hospital, while they're in the hospital, as well as afterwards. Here's a picture of our department. Again, one of the largest departments of neurosurgery in the country, if not the world. It's a real honor to be here. And it's always a pleasure to interact with students, whether they be graduate students, medical students, or undergrads. So hope that was interesting. Happy to, I think we have a few minutes. So if anyone would like to talk, happy to do so. And I'll put my email address in the chat if anyone else wants to reach out.
I have a question.
Sure.
What's some unexpected skills that they had to learn as a researcher and doctor?
What unexpected
Some unexpected skills, yeah.
Was that because that's a complicated question, because like, what did I expect to learn? I think I think in neurosurgery, it's one of those fields that's always advancing. And so, I always, I presumed I'd have to know how to cut heads and do, microscopic surgery, but we've actually been doing more and more surgeries with robots, to place instrumentation. There's endovascular techniques where you do a lot of work through little blood vessels. And so that, that's not what I tend to do most of the time, but the field is really advancing really, really quickly. And so we're doing things now routinely that I had just kind of vaguely known existed when I started. And so I think that a lot of that technical work when it comes to endovascular is probably the best answer.
Thanks.
Sure. Any other questions or anything anyone else would like to talk about? No? Okay. I don't know. Is that what you guys were hoping for? I'm not really sure what you guys are hoping for. Is that okay? All right, great. Anything else? Oh, great. Okay, well, look, you guys have my email. I think the next person is probably coming on in a minute or so. So I'll stick around. I'll maybe take my video off, but I'll stick around for a bit just in case anyone wants to talk. All right, well, thanks again for the invitation. I'll see you.
Thank you so much. I can go ahead and introduce Ms. Gupta. So Sonia Gupta, MPH, MBA, is a social entrepreneur, public health expert, health equity advocate, and future physician. Most recently, Ms. Gupta has worked as a consultant for public health entities ranging from local health departments to the World Health Organization. Combining her personal passions with her professional skills, she has played a key role in addressing a number of health equity challenges, including advocating for HIV decriminalization policy, establishing a regional syringe services program, and leading the state of Maryland's Zika virus awareness campaign. So in addition to founding and running her own national nonprofit focused on eliminating health inequities, she regularly contributes to the community by volunteering her efforts and expertise to organizations such as the Johns Hopkins Center for Health Equity and United Way of Central Maryland. Ms. Gupta is a graduate of Yale University, Johns Hopkins Bloomberg School of Public Health, and MIT Sloan School of Management. She will be attending Stanford University School of Medicine in 2024.
Right. Thank you so much for that introduction. Can you hear me okay? Okay, great. Hi, everyone. It is a pleasure to be here with you this evening. Understanding that most of you are pre-medical students, I thought I'd spend my time sharing 5 key lessons I've learned from a career in health equity and how that shaped my journey from public health to medicine. All right, lesson number 1, follow your passion, the path will emerge. Motivated by the disparities I observed between Yale College campus and the surrounding New Haven community, I founded a 501c3 nonprofit organization. Today, as some of you may know, is called United Against Inequities and Disease as a sophomore, the same age as some of you listening to this talk. And I'll be honest with you, I was armed with a big dream, but not equipped with a lot of skills or experience in this space. There was a lot I had to figure out along the way, sometimes by taking bold risks that paid off, and sometimes by making decisions that definitely didn't, and in fact were big mistakes. When I first started the organization, for example, I thought it would be wise to seek a fiscal sponsorship from an existing established organization so that my team and I could focus on our mission and not really have to handle all of that administrative responsibilities that comes with running a nonprofit. The first years of operations were conducted under that arrangement, and essentially after we proved our concept and achieved more success than anyone had expected in that time frame, the organization that we were seeking fiscal sponsorship from outlined the terms of the arrangement and essentially demanded fees from students to fund their administrative costs. I believed strongly back then, and just as much as I do now, that would go against UAID's value system to charge students any sort of fee related to administrative costs. It doesn't seem right to exclude students who may not be able to afford those costs, especially for an organization dedicated to fighting inequity. So when it was apparent that these fees were non-negotiable on behalf of the sponsor, I decided to take the bold risk to forego their support, their security, and run UAID independently. I never wanted again to be put in that position where I felt forced to compromise our values. That risk paid off, but it came with a lot of new lessons along the way. And it's actually my desire to run and grow this organization to the best of my ability that motivated my formal training in public health and business. The next big lesson came during my time at Johns Hopkins Bloomberg School of Public Health. UAID today is actually very different from UAID when it first started. For the last decade, our heart has been focused on our domestic local community issues. But we were actually founded as an international service organization. So from 2008 to 2012, we organized a number of service trips from Panama to Sierra Leone to Uganda to Haiti. And it wasn't until my education during the MPH program that I came to realize that as a student organization, we were by definition a temporary presence in the community. And I realized that any solution or intervention designed for that community has to be informed, if not led, by that community itself. Doing that is not only respectful of the population we may be in a position to serve, but it often leads to more effective and sustainable solutions anyway. So after consulting with my board, we made the really difficult decision to focus our efforts domestically and specifically partner with communities in which our students live and work. So in this case, it was my formal education that illuminated my mistake. We lost some members, and certainly a lot of time and effort and energy had to be spent to make this monumental shift. But I promise you, those are not the only two examples. There have been many more over the last decade. But by following my passion, I was able to grow the organization to more than 1,500 members across 15 universities nationally, design and lead a novel initiative in which students partner with their local communities to address domestic health inequities, launch a health equity training program, organize national conferences, publish a public health journal, and oversee numerous public health service and awareness events. But I didn't know how to do any of that from the start. I just knew what I was passionate about, and I learned everything else along the way. That brings me to lesson number 2. Oftentimes, the efforts that are most worth pursuing in life require risk. And sometimes that risk results in failure, and that's okay. I can vividly remember this one particular day. It was the spring of 2013. I was just a few miles away from where you probably are in Annapolis. And I remember feeling so exhausted, and I felt like I was so energized at the same time because my mind was whirring with anticipation. It was a day that I had worked towards for months and months. It was a day that House Bill 1154 would be heard on the floor of the Judiciary Committee at the 2013 Maryland General Assembly. My interest at the intersection of infectious disease and health policy had sparked in college and culminated in a senior thesis on HIV criminalization laws. And for those of you who may not be too familiar with that topic, essentially, most states criminalize HIV exposure, including behavior that cannot transmit the virus. These laws are mostly vestiges from the early years of the epidemic when very little was known about the infection or its transmission. But there is no doubt that current scientific evidence clearly demonstrates that these laws reinforce stigma, they discourage testing, and they contribute to health inequities. So as an MPH student at Johns Hopkins Bloomberg School of Public Health, I was selected to work as a legislative intern at the Maryland General Assembly. Shortly after starting, I proposed this comprehensive HIV decriminalization bill to my mentor, Delegate Nathan Pulliam, who very graciously agreed to support the effort. So for several months, I worked with her and the team to draft legal language for the bill, recruit support from community stakeholders, and literally campaign door to door in the House to try to garner co-sponsorship from other delegates. I am not exaggerating when I say I was completely, wholly invested in this effort. So my attempts to secure support were successful in some ways, but mostly I was met with strong resistance from the majority of stakeholders. Despite being presented with scientific evidence, the notion of HIV decriminalization was so profoundly uncomfortable to many. But it was still surprising, despite that on the morning of the hearing, a very strong and unexpected showing of a powerful political coalition opposed to this bill showed up at Delegate Nathan Pulliam's office in opposition to the bill, which effectively resulted in it being pulled from the floor of the Judiciary Committee before it was even heard. That was it. The effort I had worked so hard for months just ended that abruptly. Was this failure a disappointment? Of course. But with that failure came a learning opportunity. The experience reaffirmed the lesson that passion and advocacy has to be matched with a nuanced understanding of the system in which the change is being attempted. I really, truly believe in the power of science, and I genuinely try to understand the opposing viewpoints, but being completely honest with you, I wonder in retrospect if I had taken a more gradual, stepwise approach, could I have made more incremental advancement? The next time I undertook a similar effort, though, as a public health consultant, trying to convince a rural Maryland county to establish its first syringe services program, this exact failure and its accompanying lesson was critical in helping me achieve success. That brings me to lesson number 3. No matter what position you are in, no matter what organization you're working for, always, always advocate for those who cannot easily advocate for themselves. As a consultant for often underfunded and overstretched health departments, a core aspect of my job is to analyze the issues they face and offer actionable solutions. So the work I did for Cecil County in Maryland stands out in particular as probably one of my most challenging but fulfilling professional experiences. Very few people know this, but Cecil County actually faces one of the highest substance use related death rates in Maryland. So in 2017, I was hired by their health department to conduct a viability assessment and essentially advocate for a syringe services program. This was incredibly controversial. Despite the widespread impact of addiction on the county, there was also significant stigma surrounding the disease, and many in the county were resistant, often overtly opposed to the harm reduction philosophy and the proposed initiative. The proposal effectively seemed doomed to fail, and in the end, in the face of such odds, it probably was the most logical thing to do would have been to retreat. But I felt at my core that I was representing the voice of a vulnerable group that just could not readily speak for themselves. So first, I tried to understand the perspectives of all the stakeholders, people who would use the program, community stakeholders, importantly, supporters and those who oppose the initiative. So after a lot of individual interviews and surveys, I learned a lot from people who actively use injection drugs, health department staff, law enforcement, first responders, community organizations, treatment centers, recovery houses, schools, healthcare systems, you name it. I sought their insight. And here's what I learned. Often, most everyone could acknowledge that, yes, Cecil County experiences a concerning number of substance use related deaths. Most could even agree that injection drug use needed to be addressed. They just differed in their beliefs about which solution would be most effective in achieving that goal. And understanding that commonality and divergence helped inform my next step, evidence. Harm reduction can be a very controversial philosophy, mired by misconceptions. So by appreciating where the critics misunderstood the program, I was able to harness the power of science to explain the merits of the approach and dispel any myths while still trying to empathize with their viewpoints. To address stigma against or inaccurate preconceptions about the people who would use the program, I respectfully advocated for people who use injection drugs, relaying, with their permission, of course, the experiences and perspectives they had shared with me to guide the conversation. So using this approach at, more than 20 different community events and meetings in the county, I slowly, steadily, and ultimately successfully garnered support with each one. So with time and effort, and most of all, a commitment to advocate for those who cannot easily advocate for themselves, the Syringe Services Program, which is called Harmony, has since not only become an accepted and embraced institution in Cecil County, it's also now a model for harm reduction around the state. This brings us to lesson number 4. Don't be afraid to challenge the status quo. In 2017, I was also hired by a state Department of Health to help lead their Zika virus awareness campaign. At that time, their public health campaign strategy was informed largely by status quo, the way things had always been done. And of course, it's understandable. They, like many public health organizations, are stretched in so many different directions with limited resources. Of course, evaluative statistics are not usually something that falls within their bandwidth. And we saw why a failure to invest in public health can lead to a crisis like during the pandemic, but the topic for another talk. Essentially, the health department had, up until that point, largely employed an approach to raising awareness about various public health topics that just had not significantly changed in a very long time. And they brought me on board to challenge that status quo. In the first part of me working with them, I executed their default strategy. I made over 20 presentations to pregnant people, their families, communities across the state. I augmented those efforts by forming creative strategic partnerships with companies popular with expecting parents like Gerber and Toys R Us. But in that second part, I was able to challenge the status quo by designing and deploying a statewide survey, the first of its kind, to really truly evaluate the effectiveness of their strategy. And after telephone interviews with over 500 state residents, I was able to elucidate novel and statistically rigorous findings that will optimize future public health campaigns. So for example, I found that the odds of a male getting information about the Zika virus from the radio is 1.65 times higher than the odds of a female doing the same. How could this be important? Well, this is valuable insight because the next time the health department wants to conduct a prostate cancer awareness campaign, they know they can optimize their return on investment with radio. Similarly, I found that the odds of people in the 65 and over age group getting information about the Zika virus from TV is 4.86 times higher than the odds of the same among those aged 18 to 24 years. So if the health department is raising awareness about shingles or flu, which disproportionately affects older adults, they know how to utilize TV to maximize their impact. It can be intimidating to challenge the status quo. especially if it pertains to large, established organizations or incredibly well-known, successful individuals that we just assume must have more expertise than ourselves. But it is always worth it to ask the question, just because this is always how something has been done, does it mean that it's the best way? All right, finally, my last lesson, be authentic. So many of you are pre-med and are probably thinking about what kind of research to do, which extracurricular activities to participate in, and what types of experience to do over their summers to optimize your application to medical school. As someone who navigated this process not too long ago and will be attending Stanford School of Medicine next year, I want to share the secret of success with you. Be authentic. I know that sounds cheesy, but unlike many of you, I applied as a non-traditional student more than 10 years out of undergrad. And if you look up the statistics of someone my age being able to get into medical school, you would find that it would be close to impossible. But I managed to defy the odds. How? By being true to myself, my story, my passions. When considering research, for example, I knew that my personality was just not suited for lab work. Instead, I drew upon my unique background in business and applied it to medicine. For example, I published a first author paper in the premier journal for geriatric medicine that was actually featured on the cover of the issue. And in this paper, I discussed how lessons from domains outside of healthcare can be applied to the future of the specialty in context of the tumultuous events of 2020, COVID-19, the racial justice movement, November 2020 elections, and how all of that significantly impacted older adults. As an example, I explored how the history of the pharmaceutical industry advertising transitioned from focusing on doctors in the 1960s to the consumer by the late 1990s. In almost 20 years, advertising costs rapidly increased from approximately $1.3 billion in 1997 to $6 billion in 2016. But this seemingly excessive investment turns out to be anything but. Studies found that it empowered patients to ask more insightful questions. It encouraged conversations between healthcare providers and patients, and even helped combat stigma related to certain diseases. So if direct-to-consumer advertising has yielded such powerful results for the pharmaceutical industry, could geriatricians expand their efforts beyond traditional medical publishing to include social media, websites, podcasts that are frequented by or accessible to patients looking to get medical information? If they could, this could potentiate exponential returns in the form of patient awareness of critical health issues and positive engagement with geriatricians. In another example, I drew a parallel between Patagonia's eco-friendly mission and geriatrics' scope of patient advocacy. So for those of you who may be customers of Patagonia, you may know that customers are well known to be loyal to the brand just as much for, if not more, its commitment to an eco-friendly mission as its products. In fact, the more committed to its mission the company became, the more its sales soared. In 2011, for example, Patagonia promoted an anti-consumerist message by taking out a full-page ad in the New York Times featuring the headline, "Don't buy this jacket," above a picture of a fleece that it sells. And even while encouraging its customers to repair and reuse its clothing, sales still increased by 30% the following year. Could geriatrics apply that same ethos and advocate for and with its consumers? What would it mean for geriatrics as a specialty to more intentionally define itself as a discipline that is passionate about both providing care to older adults and also advocating for their interests? Akin to how a benefit corporation aligns incentives to include both financial profit plus social or environmental impact, geriatrics could measure its success using both patient health outcomes and its impact on patient social determinants of health. As you can see, this article was a genuine product of my unique background in business. And by staying true to my authentic self, I was able to contribute to the scientific literature in a way that was incredibly well received by the medical community. I want to leave some time for questions, so I'll end with this. I blinked my eyes, and more than a decade has passed since I was sitting in your shoes. Time marches on. And what you do with that time, following your passions, falling and getting back up again, helping those less fortunate than you, shaking up the system, and forging your own unique path, that's what will define who you are. I'll stop there. Any questions? Right, if not, I think I can give the floor back to the co-hosts.
Thank you so much, Ms. Gupta. We really appreciate it. I actually had one quick question.
Sure.
What do you believe is an essential trait for a physician to have?
I think above all, empathy, because if you have empathy for your patients, you're going to do anything and everything you can to get the other skill sets you'd need to be the best physician possible.
Thank you. And thank you so much for the information. We really appreciate it.
Of course, thank you so much for having me.
I think we'll just move on to some announcements. We have our eBoard applications which just came out. So just look in our email for more information about that. And I believe that's everything, unless Jonathan, you have anything else?
No, that's about it. And I guess like for eBoard applications, it will be due in a little bit in like around a month, so April 10th. So you have around like a month to fill that out. Yeah, other than that, that's it. Yeah.
Thank you everyone for coming to our MEDTALKS event. And thank you to all of our speakers as well. Have a good night, everybody. Oh, do we have the check-in link?
Yeah, it's in the
Yuri?
chat.
Oh, it's okay. Cool. Please check in before you leave.